Hey everyone, it's me. Welcome to this episode of Physiology 2, especially for you. In this video, we're going to cover the anatomy of the pulmonary system. So let's get started. If we look at the respiration, you can see it's all about the circulation of O2 and CO2. What you can see in this picture is basically the bigger picture in which you see certain arrows pointing in different directions. And in this and the next videos, we're going to explain exactly what this includes and which physiological processes are part of this. But first, a definition about respiration, because respiration should not be confused with ventilation. Respiration is the utilization of oxygen for metabolism in the cells and the exchange of O2 and CO2. So it's about the internal respiration that happens at the cellular level, where O2 diffuses out of the blood into the cells, and the opposite occurs for CO2. If you look at the external respiration, then we look at the exchange of O2 and CO2 that is happening within the lungs, that is related to ventilation, but not the same as ventilation. If you look at the bigger picture, then we will get back to a couple of these steps later in this video and also in future other videos. What you see is that respiration needs ventilation, but ventilation is simply the bulk flow of air in and out of the lungs. Then the exchange between O2 and CO2 happens inside the lungs, between the alveoli and the bloodstream. And then the transport of O2 and CO2 is done by the circulatory system, by the heart that pumps the blood. And in the blood we have O2 and CO2 that can be carried to the cells and back from the cells back to the lungs. So the utilization is the actual consumption of O2 that ultimately leads to the production of ATP. If you look at the anatomy of the lungs, you can see that we have two lungs, a left and a right lung. As you can see in this picture, the left lung has 2 lobes, whereas the right lung has 3 lobes. And in the middle, you can see that we have the trachea starting from the top down, from your mouth, basically. This is the trachea that will then literally branch off into very small, many small airways. In this picture, you can see the entire system that is connected to the ventilation, so to the flow of air with the area around the nose and the mouth, where the air literally has a pathway so that it can come from the environment, from the atmosphere into your body, into the lungs. And then the air can turn left, the air can turn right, and diffusion can happen. So for you, it's important to know exactly what these anatomical structures are, where they are, and what their main function is. On the right side of this slide, you can see an X-ray in which trained physios or trained experts can actually read the position of the lungs and can definitely do a lot of assessment-related conclusions. For you at this moment, it's just a matter of understanding what potentially an X-ray could see, one could see in an X-ray, but you're not expected to read an X-ray in detail. In some countries, it is a requirement, so maybe later on you might want to specialize to be able to do so. If you look at the number of branches, then you can see in this image, you can see it starts with one, the big trachea, and that branches off into a lot of smaller airways. Ultimately, you can see we have millions of small alveolar sacs, which are very thin, sort of little balloons, in which a very thin membrane separates the blood from the air. And that is what makes, in a normal healthy situation, diffusion very easy. In the other half of the picture, you can see the conducting zone, which means that these are the branches purely for the conduction of air. So only as a pathway for the air to flow. There's no exchange possible in this part of the respiratory system. The actual exchange happens in the respiratory zone, in the bronchioles, in the alveolar ducts, and in the alveolar sacs. In short, in the alveoli, that's where the real gas exchange occurs. We'll get back to that later. So the conducting zone, obviously, as I mentioned, is a pathway of the air to flow, but it also serves as a defense mechanism. So foreign objects can get trapped by your cilia and mucus, so that will prevent these strange molecules or strange chemicals to actually reach the very sensitive, small, delicate alveoli, for example. Furthermore, warming of air, moistening of air is very, very important, and that's something that you might have noticed in very extreme cold conditions where the cold air really can hurt your lungs. So a normal function of the conducting zone is that it will gradually warm up the air, make it a little bit moist so that the lung tissue will appreciate this a little bit more. And obviously, I'm speaking to you right now thanks to the vocal cords, and that is also what makes a very important part of the conducting zone, that by having the airflow passing your vocal cords, it's possible to make sound. So for this lecture, that's very helpful. And of course, also the pathway of air is very important for me to be able to teach and breathe and speak all at the same time. If you look at the respiratory zone, you can see clearly it's for the uptake of O2 out of the blood, out of the air into the blood, and the opposite is true for CO2. And at the cells, for example, the active muscle cells, as mentioned, the opposite occurs. And then indirectly, acid levels are also regulated by the respiratory system. So what happens in the respiratory zone will have a direct impact on the acid levels, because CO2 and acid are very closely connected. How? That's for a later video. If we dive a little bit deeper into anatomy, then you can already see a very beautiful picture right here, where you see all sorts of small little balloons, alveoli, within a very extensive network of capillaries surrounding them. In this picture, you can see a cross-sectional cut through the same alveoli, plural. Alveolus is singular. And here you can see this very extensive network of capillaries. And that's very important because in healthy lungs, at least, the capacity of the capillary system is huge and definitely causes some overcapacity for diffusion. On the left-hand side, you can see that all these small alveoli are also interconnected, so air can easily flow from one alveolus to another, and that will make up for a huge surface of diffusion, pretty much the size of a tennis court. This is a beautiful picture taken from a real lung. So if you've ever visited those exhibition events where you see expositions of body parts or whole bodies, then this is definitely something that is interesting. Ethically, there might be some concerns, definitely, but content-wise, this is a very nice example where they have basically colored a real lung to show what the extensiveness is of this network. So it's a great picture. Of course, the colors are artificial, but they will clearly illustrate how extensive this network is, and that also makes up for this huge, huge surface. And the main reason why lung capacity, for example, in healthy people is never going to be a limiting factor for diffusion, and therefore also not for exercise. In this picture, what you can see is the connection between the lungs, the blood, and then in between you have this little membrane. Right here in the middle, you can see one alveolus where there is a cross-sectional cut made, so you can see how the different capillaries are actually surrounding the alveolus in order for diffusion to be possible in pretty much any direction. On the right, to scale, you can see that the thickness of the membrane is very, very, very thin. Compared to a red blood cell, it's super thin. So there's not really a barrier for diffusion because the pressure difference or the gradient, the concentration difference between, let's say, the lung for O2 versus the blood will make for a beautiful diffusion path through the respiratory membrane. And then the red blood cell is basically waiting for the O2 molecule to capture it, to bind it, and to transport it. That last step will be covered in a later video, but this will give you already an overview of the very, very subtle anatomy and how that connects to the physiology. This is an example of how the lungs are positioned inside the chest in general. And the most important thing to realize is that the lungs are not connected by any muscles or other attachments really, but they're actually glued into the chest wall through a sort of a connection of two pleura. So one membrane on one side, one membrane on the other side, and that will make the lungs actually sit within the chest. But thanks to this connection, they can expand and recoil with the chest, and that's how, as we will discuss later, you are able to breathe. So we have these two pleura, and in between those two pleura, there's actually a negative pressure, which means there's a vacuum. And that vacuum is basically created by these two membranes that are not really connected, but basically in between they have some lubricant that will allow the pleura to move relative to one another in order to not have any friction. And if one of the outer membranes wants to move out, automatically the inner membrane will move with the outer membrane, and that will automatically have the lungs stretch and expand with the chest movements. On internet you can find an animation about the picture that I showed you in the previous slides to bring it a little bit more to life. But the most important message is to understand that the lungs are basically connected to the chest indirectly through these two pleura. So how do we breathe? Well, you all do it, you're doing it right now, but you're usually not conscious about this, which is good. But what you basically have to do is just move your chest wall out in order to increase the volume of your thorax. And then we have a couple of laws from physics that will explain that if you increase the volume of your chest, instantly the pressure will go down. And because of a pressure difference that is then created, air will automatically flow in from the atmosphere into your lungs. So fresh air is taken in by inspiration, which is accompanied by expansion of your lungs, whereas expiration is where you want to get rid of CO2, for example, and that is achieved by reducing the volume of your lungs, and that is usually done by reducing the volume of your chest. In this picture, you can see the whole sequence from rest to inspiration and to expiration. On the left side right here, you can see that if there's no pressure difference between the atmosphere and inside the lungs, nothing is happening. There's no airflow because everything that we do regarding inspiration and expiration is just based on pressure differences. What we see in the second picture is when you are expanding your lungs, automatically the volume will increase. Sorry, if you're expanding your chest, automatically the volume of your lungs will also expand. That will automatically trigger the pressure to drop inside the lungs, Boyle's law. And automatically, because of this pressure difference, you can see that air basically wants to move in to equalize the pressure difference. So physiology in this example is basically just physics and a combination of chemistry, because it's all about pressure differences, gradients, etc. So once the air has actually flown in, if the airflow was finished and the pressure difference between inside the lungs and the atmosphere is equalized, the same, no more air will flow in or out. So you would have an expanded chest, but no more pressure difference, so no more airflow. For expiration, you have to do the opposite. So basically, you expand, so you reduce the volume of your chest, which will then increase the pressure inside the lungs, and air will automatically be pushed out because the air wants to flow from the high pressure to the lower pressure in order to make it equal again. In this video, you will see a nice explanation where you also see visually the variables displayed. So I'm going to play this video. I'm going to sit back and you can watch the video. After the video, I will pick up again and move on with the next slides.
Expiration, barometric air pressure and alveolar air pressure are equal. Therefore, no movement of air into or out of the lungs takes place. Inspiration begins with contraction of inspiratory muscles to increase thoracic volume. This results in expansion of the lungs and an increase in alveolar volume. The increased alveolar volume causes a decrease in alveolar pressure below barometric air pressure, and air flows into the lungs. At the end of inspiration, the thorax and alveoli stop expanding. Airflow into the lungs causes alveolar pressure to become equal to barometric air pressure. Because the pressures become equal, no more movement of air occurs. During expiration, the volume of the thorax decreases as the diaphragm relaxes and the thorax and lungs recoil. This results in a decrease in alveolar volume and an increase in alveolar pressure. Since the alveolar pressure is now greater than barometric air pressure, air flows out of the lungs. Air continues to flow out of the lungs until alveolar pressure becomes equal to barometric pressure.
All right. I hope that video was nice and clear. On internet you can find the original one, so you can always replay just this video later on.
Expiration. Barometric.
Let's just move on to the next slide where we're going to discuss the pressure differences. So I mentioned the word already before, pressure. That is what most of the ventilation is based on. So to have a pressure difference between the alveolar wall and the chest, that will allow the lungs to remain open. And because of this negative pressure between the two pleura, we can actually have the lungs expand and recoil together with the chest. But there's one important example of an incident or an injury where you can see that this whole physiological process is lost. And that is what we call, for example, in this case, a pneumothorax. And that is when this intra-pleural pressure is no longer negative. And therefore, the expansion of the chest will not automatically be accompanied by an expansion of the lungs. In the next picture, I'll show you an example that you can see here. So this is a picture from Vander where you can see all the different numbers. And to answer already some of your potential questions in advance, yes, you do need to understand the numbers, although the exact numbers are not really what this is all about. The main idea behind this is to understand that there's a negative pressure in between the two pleura, a vacuum, if you will, which means that automatically the outer membrane, if it is going to expand together with the thorax, will automatically bring out as well the inner membrane. But with the exception of a pneumothorax, for example, a stab wound, or sometimes because of an autoimmune issue, you can have an air leakage, either in the inner membrane or the outer membrane, and that will allow air to flow in through this hole. So if there's a puncture from the outside, a broken rib, for example, can also do that, then you could have air flowing from the atmosphere, not through the normal pathway, but directly through the hole, and that will recoil the lungs, so basically you have a collapsed lung, and the complete function of that lung is gone. If that happens on one side, you still have one other lung remaining, but if you have that on two sides, then it's very, very serious, and if it's not treated instantly, then there's no possibility for you to survive because you cannot breathe anymore. So a pneumothorax should be solved or basically stitched or glued or fixed by a surgeon, and they have special procedures for this in order to close the gap to recreate this vacuum so that you can start the normal process again and can have the lungs expand again together with the expansion of your chest. Here again, a picture of an X-ray where on the left side there's still a normal functioning lung, but over here, hopefully it's also clear in the video, you can see that there is a line that is supposed to be here on the outside, but it's actually now moved in, which shows that the lungs have collapsed and have lost their function, and the lung membrane is actually right there and will not be able to move with the expansion of the chest anymore. So on an X-ray, you can clearly see a situation like this, a pneumothorax. And here again, the same, but now in a more clear visual way, where on the left side you can see the lung being collapsed. There's a lot more room now between the two pleura because this negative pressure is gone, whereas here you can see that the two pleura are really close together and only separated by a little bit of lubricant and furthermore just this negative pressure. So to summarize the anatomy of the lungs, they basically consist of many, many alveoli, and the alveoli are just these little balloons or little sacs that form a huge, huge surface. What is interesting is that the inside of the lungs, so the inside of the alveoli, basically consists of a small layer of water. So the alveolar surface is lined up with water, but water has surface tension. And if you've ever jumped from a high cliff into the ocean, you definitely have experienced surface tension because it hurts if you jump from a high cliff into the water, and that is because the water molecules on the surface line up in such a way that they basically line together to form a surface that even insects can walk on. And that is something that is also happening inside your lungs. And what you can see here is that here on the inside of the alveoli, you can see you have different cells. And if we zoom into this little area in the next slide, you can see that this is what basically the inside of your alveoli look like. So there's a thin layer of water on the inside of the alveoli. But surface tension would actually cause the lungs to stretch more or less easily. So surface tension will prevent the lungs from getting stretched. So in physics, we use the word compliance to explain how easy it is, how much force basically you need in order to stretch tissue. Well, the compliance of your lungs is normally in a situation where there's no special mechanism for this, relatively low because of the water tension. But your body has specific cells, type 2 cells as indicated right here, that secrete a chemical that is called surfactant. And surfactant basically is a soapy substance that will allow the water tension to be broken, or at least partially broken. So the normal surface tension, because of this surfactant that is released, will disappear partially or completely, and that will increase the compliance of the lungs, which makes for an easier stretch in case the chest wall, for example, wants to expand. So the lungs have some natural elasticity, and then together with the surface tension, we can say something about the overall compliance of the lungs. And in healthy people, the compliance is usually quite high, which means that not too much force is required for you to stretch your lungs. But for some patients, compliance could be drastically reduced, either with a surfactant issue or with just other connective tissue issues, which could make it a lot harder. A lot more energy would be required for those people to breathe, because the expansion of the lungs, for example, would be a lot harder and would cost a lot more energy. So this surfactant is very essential, but the main question is, how does the body regulate the amount of surfactant? Well, surfactant is an interesting process, or the process of surfactant is interesting because it's like a soapy substance that is released more when the tissue is stretched. So when type 2 cells get stretched, they release more surfactant, which will make the next stretch even easier. So it's like a vicious circle that goes like a spiral going up. Because of one stretch, the next stretch will be easier. And graphically, you can see that displayed in this graph, where you see lung volume over here, and you see transpulmonary pressure on the x-axis. And then you can see here what the definition of compliance is. So it's basically how much force or how much pressure difference in this example is required for a certain amount of volume change. And if you need only a small pressure difference for a large volume change, we say the compliance is high. In plain English, it means it's easier to stretch your lung tissue. Whereas in the opposite situation, the orange graph shows a decreased compliance. So that could be a pathological situation where the patient has, for whatever reason, connective tissue issues or a lack of surfactant, which will cause that patient to have a huge pressure difference required in order for maybe only a small change in volume. So it will cost a lot more effort, a lot more energy to just breathe compared to a person with a high or normal compliance. Well, if you look at the whole process, to sum up the whole process of respiration and ventilation for the end of this video, you can see that it all starts with the expansion of your lung volume, and that could be done by an expansion of your chest. If you move your ribs out, if you move your diaphragm lower by contracting it, automatically the volume of your lungs will increase, which will make the pressure inside the lungs drop. If the pressure in the lungs is lower than the pressure in the atmosphere, air will flow in. Expiration is the opposite. You want to make sure you relax the diaphragm, so the diaphragm will push up, your ribs will come down, the lung volume will drop, pressure inside the lungs will increase, which will cause a pressure difference in the opposite direction and will cause air to flow out from the lungs back into the atmosphere. Expiration. All right, that was the end of this video. Please let me know how you liked it. Thank you very much for watching, and well done on completing your first video. So especially for you, some confetti to finish up this video, and I hope we will see you in the next video.